All right, welcome to The Explainer. Today we are diving deep into something that, well, gives every surgeon nightmares, the consultant viva. We're going to break down a breast cancer case, but here's the twist. We're not just looking at the medicine, we're looking at the strategy, the stuff that really makes the difference between passing and, well, not passing.
So, what is the real difference between a pass and a fail in one of these high stakes exams? I mean, that's the question, right? Is it about knowing some super obscure fact from a paper in 1982? Or is it just about not making one tiny mistake? Actually, no. It's much simpler and also much more fundamental than that. As you're going to see, it all comes down to having a system, a safe, repeatable system.
And look at this. This right here is the map. It's not a secret. This is literally what the examiner has in front of them, their checklist. From this point on, everything we talk about, that's a point you can score. See, passing this thing isn't about being some kind of genius who pulls a rabbit out of a hat. It's about being systematic. It's about being safe. It's about ticking every single one of these boxes.
Okay, so let's start where every patient encounter starts, the basics. We're talking about the foundation, the history and examination. Before you even think about fancy imaging or talking about surgery, you've got to show them you've mastered this. Honestly, this is your first big chance to really shine or to fall flat.
So you start taking the history, right? And the examiner, they're not just passively listening. They've got a mental checklist. They're listening for keywords: menarche, menopause, family history, HRT. These aren't just filler questions, They are critical data points, and for every single one you mention, you can practically hear them ticking a box in their head. Check. But if you miss one, that's when a little question mark starts to form right next to your name.
And when it comes to symptoms, you got to think in two gears at once. First, you're a detective on the local scene, right? Nipple discharge, pain, a lump, all the stuff happening in the breast itself. But then, click, you have to shift gears and think bigger. You've got to broaden your search for signs that things might have spread. Are you asking about back pain, headaches, shortness of breath? Because when you do that, you're showing the examiner that you're already thinking 3 steps ahead. You're not just thinking about a lump, you're thinking about potential mets to the bone or the brain.
And here's a pro tip, something that a lot of people miss. Don't forget to ask about previous imaging. Seriously, asking about the patient's last mammogram is such a consultant-level move. It just proves you get it. You understand that this patient's story didn't start the moment they walked into your clinic. You're looking for changes over time, and that is the mark of a senior, thoughtful clinician.
Now for the physical exam. Honestly, you should think of this like a performance, a well-rehearsed dance. You have to be super systematic and, this is key, you have to say what you're doing out loud. I am now inspecting for. I am now palpating the. So it's expose, inspect, palpate, and then lymph nodes. You follow that exact structure every single time. It tells the examiner you're safe, you're thorough, and you won't fall apart under pressure. And then, just when you're in the groove, the examiner throws you a curveball. They'll say something like, okay, so on examination, you find absolutely nothing. No masses, no nodes, the breasts are average size. This is a classic exam trick. They're not trying to be mean, they're testing you. They want to see if you'll panic or if you'll stick to your guns and trust your system. All of a sudden, that history you took and the mammogram report become even more critical. Right, so just because the exam is normal doesn't mean the patient is fine, not at all. Now you have conflicting information, don't you? The history might be suspicious, but the exam is normal. This is where you really get to show off your clinical chops. How you navigate the investigations from here, that's everything. Okay, so your next steps have to be precise. The language you use is so important. You don't just say, let's get a mammogram. No, you say, I'd like to request a diagnostic mammogram of both breasts. Why both? Because you know cancer can be bilateral. Then you follow up, and a complementary ultrasound of both breasts and axilla. And for the finishing touch, you ask for the BRAD score. When you do that, you're telling the examiner you speak their language. You understand radiology risk stratification. You know that a BRAD's 4 or 5 means you absolutely have to get tissue. And just like that, another test. The examiner says, okay, we can see a suspicious area on the mammogram, but it's not visible on ultrasound. How do you get a biopsy now? Boom! They've just taken away your go-to tool. Ultrasound guidance is gone. What's your plan B? Your answer to this question is what separates the people who pass from the people who get distinctions.
And the answer you're looking for, the one that makes the examiner nod and tick that box, is stereotactic biopsy. Just saying those two words and then briefly explaining what it's for, for things like microcalcifications that you can only see on a mammogram, that's a huge win. That's a top-tier answer. You've just confidently solved a complex clinical problem.
So great. You've got the biopsy. Now the examiner leans in and asks, so the path report comes back. What are you looking for? Your answer has to be a slam dunk. You need to hit these 4 key points. Is it invasive or DCIS? What's the histology and grade? And what's the hormone receptor status? ER, PR, and HER2. Why? Because the type and grade tell you about the surgery, and those receptors, they dictate the entire medical oncology plan. These are absolutely non-negotiable points.
Okay, so making the diagnosis, that's really only half the job. Now for the main event. You have to build and clearly explain a management plan. It has to be safe, it has to be based on evidence, and it has to involve multiple disciplines. This is the moment you pull everything together.
So let's say, in our case, the biopsy comes back as pure DCIS, ductal carcinoma in situ. The right surgical answer here is a wire-guided wide local excision. But you know what's almost more important? Knowing what not to do. It would be totally inappropriate to do a routine nodal assessment here. Why? Because pure DCIS is by definition non-invasive. It can't spread to the lymph nodes. Stating that you wouldn't do that shows real surgical judgment.
And remember, your job isn't done when you close the skin. The exam continues into the post-op period. The examiner wants to know what you'll do next. You've got to say you'll review the final pathology for margins. You have to have a plan in case it comes back with unexpected invasion, like doing a sentinel node biopsy then. And maybe most importantly, you have to show that you can handle the human side of this, that you can talk to the patient who might be upset with real empathy. Look, a consultant is not a one-person show. You can't work in a silo. A huge part of your management plan has to be about the team. You have to explicitly say, I will refer the patient to radiation oncology and to medical oncology. Saying that proves you get it. You understand that modern cancer care is a team sport. And forgetting to mention the team, that's a huge flashing red flag for the examiner. And last but not least, you have to show you're thinking long-term. You need to lay out a really clear, structured follow-up plan. Clinical reviews every few months for the first couple of years, then annually. A mammogram 6 months after radiation, then every year after that. When you lay it out like this, you're proving you're not just a technician who removes a tumor. You're a physician who's caring for a patient, a survivor, for years to come. That's the final piece of the puzzle. Okay, we've talked a lot about how to pass. Now let's talk about the opposite, how to fail. And you know what? This might be the most important part of our whole discussion, because we're about to cover the fatal mistakes, the critical errors that if you make one, there's just no coming back from it in an exam like this. And let me be clear, these are not small slip-ups. We're not talking about forgetting a minor detail. The examiner's marking sheet literally calls these fatal mistakes. If you make one of these errors, it shows a massive fundamental gap in your knowledge. It shows that you might be unsafe. So let's really spell out why these are so bad. Doing a full axillary dissection for pure DCIS, that's dangerous overtreatment. You're putting a patient through a major operation with a lifelong risk of lymphedema for absolutely zero benefit. Not going back to get clear margins, that's undertreatment. You're knowingly leaving the patient at a higher risk of the cancer coming back. And forgetting the oncology referrals, that's a total failure of the whole multidisciplinary approach. See, they're all fundamentally unsafe decisions. So when you step back and look at the whole picture, at the entire marking sheet, you start to see the pattern, don't you? This exam, this viva, it's not some random, unpredictable chat. It's a structured audit. It's a test of your entire clinical process, and it's all designed to answer one single question. Are you safe, and are you systematic enough to be called a consultant? And really, that's the number one thing I want you to take away from all this. Success here isn't about memorizing every single paper ever published. It's about having a solid, safe, repeatable system that you apply to every patient every single time. If you master the system, the pass, it just naturally follows. So use this framework we've just gone through as your roadmap. Practice it, talk through cases out loud until this whole system is just second nature. Figure out where you're a bit shaky and work on those areas. That way, when you walk into that exam room, you're not walking in with fear, you're walking in with a clear, confident plan, just like a consultant.